Thanks very much. I'm delighted to be here today at the Demystifying Medicine course, and I'm Maggie Larché. I'm a rheumatologist. I have an interest in basic science, but my predominant interest is in rheumatoid arthritis and scleroderma. And today I'm going to be talking to you about scleroderma, and we've got the privilege of having our patient Claudia come to talk to us today. And then Mark's going to talk about the basic science elements of scleroderma. So really the objectives for today are to describe clinically pertinent points for medical students and pre-medical students. I know that many of you will be going on to a career in medicine, which I have to say is a phenomenal career. I'd like to give a little bit of insight into the life of a patient with scleroderma. And then Mark's going to talk about how basic science can really help us push the boundaries of medicine and help us with new treatments and new ideas of how to treat. So scleroderma or systemic sclerosis, we use those terms interchangeably, and we probably shouldn't. I'll tell you why in a minute. But sclero means hard or thick in Greek, and derma means skin, so hard skin. It was first described apparently by Hippocrates. I wasn't around then, but apparently it was described by him. And in 1945, I wasn't around then either, but the first description of an association with systemic disease was made, that the thickened skin can also pertain to thickening in some of the internal organs. There are many aspects of systemic sclerosis, and during your medical careers you'll be asked to delineate the features of many of the autoimmune diseases, and I tend to like to go from fingertip to head and down, and then you don't miss things. But I've given you a huge number of descriptors of some of the facets of systemic sclerosis, and as you see, that's why it's called systemic sclerosis, because it can affect many systemic organs. And in terms of a pearl, a take-home message for you, scleroderma usually presents with Raynauds, and I'll talk to you in a little while about what Raynauds is. And it presents with puffy hands, so patients present with cold, white, red, blue hands and puffiness in their fingers. It can particularly affect the lungs, the kidneys, the heart, and of course the skin. But it can affect almost any organ. It frequently overlaps with other autoimmune illnesses like lupus, autoimmune thyroid disease, for example. So what about Raynauds? Raynauds is a phenomenon which occurs in mostly women. In about 10% of women will get Raynauds. It usually occurs in the pubescent area, time of your life. And Raynaud described cold extremities which change color in a tri- or biphasic mean, so blue to white or red to white with blue or red in addition. And it's due to vasospasm of peripheral vessels. It's usually primary, and that means there's no other associated cause of Raynauds, or it could be secondary, and that's when I get excited, the secondary causes of Raynauds. We'll go into that in a minute. So men can also get Raynauds. It's much less common in men, but in anybody, men or women, who use those big, heavy vibrating tools to push down tar macadam, for example, when working on the roads, they're the ones who might also be predisposed to Raynauds. So these are photographs of Raynauds taken by me. Some of them are not so good, but as you see, the fingertips are totally white. Does anybody in the room get Raynauds? I do. So your fingers in the cold can go completely white, but often go blue and red. So the important thing to note is that primary Raynauds is not associated with any other connective tissue disease. It often begins in adolescence, as I said. All you really need when you're determining what Raynauds is, or whether this could be primary or secondary, is a really good history and examination. Look at them. Blood work you don't usually need to do, and it's usually not severe. Secondary Raynauds, on the contrary, is associated with connective tissue diseases that we see commonly in rheumatology, in particular scleroderma and lupus. Also rheumatoid, mixed connective tissue disease, and other autoimmune diseases that we see. And then there's a differential diagnosis of other diseases that particularly affect men. Thromboangiitis obliterans, or Berger's disease, occurs in young men who smoke. And then other diseases like antiphospholipid syndrome and cryoglobulinemia and the weird and wonderful stuff that we as rheumatologists see. And you see at the bottom there in red, I've written in 90% of patients with scleroderma, they have Raynauds usually as the presenting feature. So when should you suspect that Raynauds is not just primary Raynauds like I've got, but actually Raynauds that's secondary to an autoimmune condition? If somebody presents at an older age, if a man presents with Raynauds, maybe start thinking this might not be normal. If they have Raynauds and little ulcers on their fingertips, digital ulcerations, or any other features of an autoimmune disease. Now, I've purposely included this slide to make it really busy and very difficult and make you go, oh my goodness, I'm going home. Because there are lots of players and we really don't know who started it. Well, who started it? I hope this doesn't happen in your classrooms, and especially today. But this is a sort of fight breaking out between all these players and all these cells. Who started it? Well, you could say, who cares, be quiet and just sit down and get on with your work. And in some respects, we do that in autoimmune diseases. We just damp down the immune system. We say, I don't care who started it, let's just quiet you all down with general immunosuppressants. And we use this commonly. And our friend, Professor Alan Tyndall, made these slides and graciously agreed to let me use them. So the key things about this slide are there's really a triad of problems. There's vascular dysfunction, there's activated fibroblasts, there's immune dysfunction, all generating the problem of fibrosis. So as I've said, the vascular dysfunction can relate to some of the systemic features of scleroderma, including pulmonary hypertension, renal manifestations. The inflammation and immune dysregulation can cause autoantibodies, which are frequently seen in scleroderma. And the fibrosis can affect skin, lungs with pulmonary fibrosis, the kidneys with sclerosis, and the GI tract can be very, very disabling. So what about terminology of scleroderma? I told you that we use scleroderma and systemic sclerosis interchangeably. We do in sort of common parlance, but to be precise, the scleroderma that I see, I should always call systemic sclerosis, because in the blue on the left of your slide here, you see the features of scleroderma that should indeed be called scleroderma because it's thickened skin that dermatologists see. They see conditions called morphea and linear scleroderma. And those are the pictures on the bottom left there. They're little patches of skin or streaks of thickened skin. And the streak is also called en coupe de sabre, a slash of the saber. I call that the Harry Potter sign because it really reminds me of Harry Potter. Whereas in red there are the conditions that I see in my clinic. This is systemic sclerosis. And the terminology is really, really confusing because we have localized scleroderma and systemic sclerosis in blue and then red. And then the red is divided into limited, and that pertains to the amount of skin involvement only. It's not that it's limited to just the skin, it's limited in its skin involvement, but it's still systemic sclerosis, i.e. the organs can be involved. So the amount of skin involvement can be limited or diffuse. And they each have their own sort of manifestations. We've got new criteria to aid in early diagnosis. The puffy fingers is a new classification criteria along with Raynauds phenomenon, and looking for dilated nail fold capillaries. And you see on the images here on the bottom, these are dilated nail fold capillaries, which you can see with this very expensive magnifying glass with a light. I know this is really expensive because my kids lost this and I had to buy a new one, and $500 for a new one. That was a really expensive week of no pocket money. And then sometimes we use blood work, including an ANA, to help us with the diagnosis. Early diagnosis allows us improved monitoring and treatment of complications. We know that patients with diffuse disease are more likely to get pulmonary hypertension, pulmonary fibrosis, and renal disease. ILD is interstitial lung disease. PAH is pulmonary arterial hypertension and renal disease. And we know that because those organs get involved, that we can monitor them. And as Claudia tells you, I'm always at her to get things monitored. And it's probably quite annoying. But I monitor by echocardiogram, scanning the heart, doing lung function tests, PFTs or pulmonary function tests, looking at renal function, and keeping a really close eye on their blood pressure. And I'll tell you why that's important in a minute. And the other reason that early diagnosis is important is that we've got better treatments now, and we're continually getting better treatments. So, as I've said, another pearl for today, new criteria make it easier to diagnose systemic sclerosis earlier, and we should always consider it in patients with Raynauds and puffy hands with dilated nail fold capillaries. So why am I interested in, and so what? When you're describing the difference between diffuse and limited, it is really quite important, because as you see here in blue, this blue graph shows skin thickness, which the blue line depicts diffuse systemic sclerosis. And these patients get really tight, thick skin early on in the disease. They get joint contractures because their skin's contracting and they cannot extend their fingers. But this happens early on in the disease. They also get gastroesophageal, gastrointestinal involvement, lung involvement, heart involvement, and kidney involvement. And it's the kidney involvement right at this early stage of disease that can cause problems with mortality. Whereas the limited systemic sclerosis have a more benign course that's really gradually gradual thickening of the skin, and it's particularly characterized by Raynauds and digital ischemia causing necrosis and ulcerations, and problems swallowing. Some of you may have heard of the syndrome called Crest Syndrome. Anyone heard of that? Crest is the acronym to make you remember some of the features of limited systemic sclerosis: calcinosis, Raynauds, esophageal dysmotility, sclerodactyly, and telangiectasia. But, excuse me. This is why we like to differentiate between diffuse and limited. So what about the risk factors for a poor outcome in systemic sclerosis? When I first meet a patient, how do I determine how intensive to be with my monitoring and how worried to be about their health? If they present with diffuse skin involvement, they're straight away at worse prognosis. If they've got protein in their urine, they've already got a little bit of renal involvement, and that's something to worry about. If they've already got pulmonary arterial hypertension based on their echo, that's something to worry about. Pulmonary fibrosis, New York Health Classification in terms of the amount of exercise they can do, and late onset Raynauds. Somebody presenting in their 50s with Raynauds, that's a risk factor for a poor outcome. So I'm going to move on now to management of some specific aspects of systemic sclerosis, and I'm particularly going to talk about management of Raynauds, GI involvement, pulmonary fibrosis, and renal crisis. So what about Raynauds? There are conservative measures which are great to start with, to ask the patient to stop smoking and to try and avoid the cold. It's quite difficult in a country where it's normal to be minus 20 or so in the winter. They need to keep their skin nice and moist with emollients, so keeping cream in their handbag is always useful. avoiding drugs like beta blockers. Beta blockers are often used in heart attack patients after a heart attack, so avoiding those is useful. Cocaine's a kind of trendy drug, and I always ask my patients whether they're using cocaine if they've got a new onset of Raynauds. It's really important to exclude that. And then simple things like buying heated gloves and heated socks are very helpful. And then we move on to medications, and the calcium channel blockers, you'll hear a little bit more in the rest of my talk about the calcium channel blockers. All of these medications are designed to open up the peripheral vessels. Nitrate patches as you would use for angina or heart disease, and then angiotensin receptor blockers. And then the next line treatments are infusions of drugs. We can bring people into hospital for infusion of a drug called a prostacyclin, and you've probably heard through some of your courses about prostacyclins opening up, being very potent vasodilators. The problem for us right now is we have to bring them in with a central line, and we have to bring them onto CCU for 5 days, the coronary care unit for 5 days, in order to get this medication. So it's a hassle for the patient. It's a very expensive way to do things. So we're working on different ways of administering that. And then talking of expensive drugs, we're also able to use the PDE5 inhibitors now, such as Viagra and Cialis, for severe digital ulceration and Raynauds. So we use those. Also, antidepressants are useful. We don't really know why, but antidepressants can be useful in patients with severe Raynauds. And then we can resort to surgery if we need to. We can cut the sympathetic drive, cut those sympathetic nerves, and that can help open up those blood vessels. So this is just a recap. There are some specific treatments for Raynauds, and these specific treatments will prevent damage. And that's the key for us, is to treat it early and prevent damage from happening if we can. What about GI manifestations? Again, I'm not going to go through all of these individually, but you see on the left side that there are many, many manifestations of systemic sclerosis that can affect the GI tract. And there are also many types of treatment. The bottom one there, incontinence, is a issue that we really were not aware of until we started asking, and patients are actually commonly have problems with fecal incontinence. I have a young man in his 40s who is holding down a full-time job working for Toyota, and he's really troubled by leakage, fecal leakage, and as you can imagine, it totally destroys his life. He doesn't want to, he does want to, but he doesn't want to find a girlfriend. He'd like to settle down, but he feels like he can't. And in fact, I've just referred him up to a surgeon in Montreal who will do the equivalent of a heart pacemaker. She's going to do on his sacral nerve. You get literally a little pacemaker under the skin in your buttock, and they stimulate just the sacral nerve to help with anal tone. So these are issues that are incredibly debilitating for some patients. And I just used him as a little anecdote for you. So GI treatments, we've got some reasonably good treatments. We use high-dose proton pump inhibitors to help with the problems with indigestion and acid reflux. We can use stimulants to stimulate the gut. And as you can imagine, if your gut, instead of working in a sequential manner, kind of doesn't know when to squeeze and doesn't squeeze properly, we can use drugs to try and help that process work properly, and domperidone and prucalopride both help with that. So PDE5 inhibitors, I mentioned briefly, they're useful in digital ulcers, pulmonary hypertension, and erectile dysfunction, of course, which is also another problem that some men with scleroderma have. So a little pearl, why do you use your little blue pill in systemic sclerosis? Well, there are 3 good reasons to use it: pulmonary hypertension, digital ulceration prevention and treatment, and erectile dysfunction. Moving on to renal crisis, it's the leading cause of mortality, or one of the leading causes of mortality in patients, and it can kill people really quickly. It's portended by an increasing blood pressure. you might get a microangiopathic hemolytic anemia, and that's because of the vascular dysfunction. The vessels are all inflamed, and they cause damage to the red cells, which then cause a hemolysis. And so you might get that, and you might obviously get a rising creatinine if your kidneys are being damaged. I've written here there's a 25% mortality at 1 year if you have scleroderma renal crisis, and you've got up to a 50% chance of developing what's called end-stage renal failure, which means you're on dialysis for the rest of your life if you don't get a transplant. And once you're on dialysis, you have a 2-year mortality of 50%. It's a disaster. These patients who get scleroderma renal crisis, disaster. And who gets it? Well, men, people with diffuse systemic sclerosis, you've heard that repeatedly now, and people who inadvertently get high-ish doses of steroids for whatever reason. So prednisone for an acute exacerbation of asthma. You've got to beware of steroid use in patients with diffuse systemic sclerosis. And we know that calcium channel blockers may be protective in these patients. But we also know that we can treat it. If we treat it aggressively, we can get control of the scleroderma renal crisis early, and their outcome is much better. So I ask my patients to monitor their blood pressure 3 times a week, especially in the early stages of their disease. And I'm careful with the doses of steroids that I use, and I treat really aggressively with ACE inhibitors. There's lots of hope on the horizon for patients with scleroderma. There are new biologics coming out to target T cells, B cells, interferons. And Mark may be talking a little bit about some of the chemokines that are involved. There's also a method of treating these patients with stem cell transplantation, which has shown to be very promising in early stages of diffuse systemic sclerosis, which I've told you has the worst outcome. If we catch these patients early before they get internal organ involvement, that can be a very useful treatment. And there's my friend Alan Tyndall who lent me those slides. So the pearls I've talked about are clinical with regard to starting with puffy hands and Raynauds phenomenon. I've talked about the red flags in Raynauds. Most Raynauds, I'd say 99% of Raynauds is not due to another cause, but sometimes you have to be aware. I've told you why it's important that we can now diagnose earlier, and to talk to you about the risk factors for poor outcome, and then gone through some of the treatments of some of the aspects of systemic sclerosis. So we can focus on earlier diagnosis and intensive monitoring. We can treat supportively. There are specific treatments coming out with some new hope. And my last pearl of the day is that it's a team game. Because it affects so many organs, we need help from gastroenterologists and pulmonologists and cardiologists and so on. And even immunologists sometimes. So we formed the Hamilton Scleroderma group, and there's a little bit of information on that website if you feel so inclined. And these are some of the ugly mugs that are involved in it. So thank you to Kjetil for inviting me to the Demystifying Medicine program, to my multidisciplinary colleagues at Hamilton. Ellen McDonald's our nurse practitioner, and this is her up here as the quarterback. Of course, my rheumatology colleagues and the Scleroderma Society of Ontario have funded the Hamilton Scleroderma group and a PhD studentship that's currently working with Mark. So if there are any questions, even offline, please just email me at a later date. And I'll take any questions now pertaining to my part of the talk, or we can leave them all to the very end, whichever you prefer. And if you'd prefer, then we can, I'd love to say a huge welcome and thank you to Claudia, who is our patient for the day. Thank you.
Okay, so I was probably in my early 20s, and I just remember walking on campus at Mac, and my hands were blue. And so it was more alarming to friends that were looking at my hands than myself. And then I started getting these weird ulcers, and so I looked into it with a doctor in the campus, and she referred me to Dr. Kaminska at the time, who was my rheumatologist. But due to my over work ethic, I kind of delayed my appointment a few years, and then I finally did go see her when things started getting a little bit worse. And yeah, she diagnosed me with the scleroderma right away.
How long had you had the Raynauds before your ulcers developed?
Probably about a year.
Right. So an acute onset of Raynauds, which is unusual, it usually kind of creeps up on people. Usually occurs when you're about 15 in a girl, and associated with quite rapid onset of digital ulceration. What were those digital ulcers like?
At the time, they weren't painful at all. It was just my hands would get like black spots on them,
Right.
and that's why I wasn't too worried. But as the disease has progressed over time, they've definitely gotten worse and much more painful.
And what about other symptoms since then?
So what brought my attention more closely to seeing the doctor was I started getting acid reflux, and there was changes in my body size and my face. People who hadn't seen me for a while, people from high school didn't even recognize me because I had changed so much. And then the acid reflux and my stomach problems started to worry me a little bit. I was concerned it was something more serious. And so finally I thought, okay, maybe I should go see someone. So those would have been the next things that hit me.
Yeah. So Claudia brings up something that I didn't really highlight in my talk, but facial changes can be really upsetting to patients. What happens is the skin of the face gets tighter, and that kind of draws the skin back. And actually patients, older patients say, oh yeah, I feel like I've had a facelift, because actually they don't get wrinkles like the rest of us. And there can be quite debilitating little red spots called telangiectasia across the face or the fingers. And then the other thing that can happen is that because the mouth gets tight, opening up your mouth gets tricky. So getting a spoon in or going to the dentist can be very troublesome. Do you have any problems there?
I do, yes. Going to the dentist isn't fun. And I was a little self-cautious because then I started to show obviously more teeth because the skin pulled back. So I decided to do braces a few years ago, and yeah, that wasn't a good idea. So no. But yeah.
Didn't enjoy that
at all.
And what about medications? What kind of medications are you on right now?
Okay, so to help with the blood flow, I take nifedipine, I believe.
Right, so calcium channel blocker.
And I take Nexium. That's a must because the pain can get pretty severe.
So that's a proton pump inhibitor to help with the reflux, the acid, and swallowing. Mm-hmm.
And currently, because my ulcers have gotten pretty bad and my breathing has gotten a little bit worse, you've placed me on Viagra.
Yeah. So that's just started. It was a bit of a battle to get it, and patients we cannot get Viagra for patients on the Ontario drug plan. They won't pay for it. But Claudia is a. Do you mind if I tell them what you do?
Yeah.
Claudia is a fantastic, I bet, teacher at a Catholic school, and she. Has good benefits, so thank goodness. It's one of my questions I don't like asking, but I have to ask her every time I meet a patient is, do you have benefits? Because some of the drugs that I use routinely in my clinical practice cost $10,000 to $15,000 a year. And if the patient doesn't have benefits, I have to then lobby the government to allow me to use that drug. Viagra doesn't cost that much, but it's still very expensive. And how are you finding the Viagra?
You know what, it's still early on, but I think there are improvements.
It's beginning to heal.
So, yes, I do believe so.
Yeah.
Yes.
Yeah.
So
tell me about your most troubling symptoms now.
Okay, so most definitely fatigue sets in, and that can get pretty troublesome, especially being a teacher and always having to be on the go. Mm-hmm. My breathing some days isn't so good. It can cause sleepless nights. But I think overall, probably my digestion and my hands, for sure, would probably be my biggest setbacks.
So how do you modify your life compared to people your age?
I should be getting more rest, but I don't. Let me think. Eating, it's probably best for me to eat smaller meals more times throughout the day. But again, with my busy lifestyle, I don't really manage that too well. My hands, I just try to keep them warm as possible. I try not to expose them to any detergents that could potentially harm them more. Yeah, things like that. When I'm at school, I don't use chalk. I've always worked for really wonderful people who've always taken care of me in the sense of making sure I'm not exposed to any chalk dust that could irritate it more. My kids are very, very compassionate, so they're very understanding if I'm not feeling well that day. So,
Tell us about some of the comments the kids have made.
well, the thing is, I'm very secretive. I'm very private. I don't want people to look at me and think that I'm sick. I don't want to look like a victim, so I won't let this disease define me. So as a teacher, the kids don't know. All they know is that I can't be outside. They often ask questions because kids, I teach intermediate, so kids are very curious. So they'll ask me why I can't go outside, and I'll just be like, I just can't be in the cold. Sometimes they've noticed my hands go blue, or there'll be days where I'm very, very pale. But you can see the concern in their face, and it's very nice. In past years, I've had kids offer to wash the boards for me, to sweep, and sometimes at the end of the year, if I'm really feeling up to it, I'll expose them to a little bit of my disease, and they're very, very good about it. So, yeah.
And what about your boss? How supportive has your boss been?
Oh, fantastic, fantastic. I couldn't ask for anything better. I can't do enough.
Teachers have to be outside in the playground, don't they, to monitor their kids?
Yes, we do, and I don't even know how to describe. It's just it's funny how people come into your lives, but definitely I've only been blessed. So, and I've definitely looked out for me like a sister figure.
Yeah.
So.
Yeah, and I think this draws upon the fact that Claudia has had to, despite the fact she doesn't really want to tell other people that she's got problems, she's had to tell her boss, and her boss has been helpful in terms of adapting her workplace environment. Have you had to adapt anything at home?
Well, definitely my furnace is up a little bit higher than most people, so it's very warm. I shouldn't be shoveling snow, so my family got me like a snow thrower, so that was kind of good. Lots of blankets, things like that, and like I said, trying to eat smaller meals, so I make sure that I cut things up more regularly in terms of washing dishes, dishwasher, things like that. So.
And you have the head of your bed up?
Yes, I should. So the nights that my acid reflux gets really bad, I just elevate my pillows. I should probably elevate the actual bed. So
that's a point about reflux. So if your mouth is as low as your stomach, it's very easy to reflux. But if your mouth is higher, even by so I suggest to people they put their bed end, the head end of their bed, on a 4-inch brick or a textbook of demystifying medicine or something, just to raise the end of their bed by about 4 inches. Then your mouth is slightly higher than your stomach. And patients say, well, I prop myself up on pillows, but we all wriggle off our pillows, don't we?
Yes.
So that's another little trick that you can tell patients to do if they're getting lots of reflux, is just get that head of their bed up a little bit.
I find too that helps with my breathing at night. If I wake up in the middle of the night and I find it's hard to breathe, if I elevate myself, then I'm better.
Yeah. Good. And how about your family? How have they been coping with all of this?
Well, because I give it a very shadow overview where I'm like, I'm fine, everything's good, everybody's happy. Everyone's been pretty optimistic, so people are really good. Friends and family have been wonderful to me in the sense of making sure that I'm comfortable, and if they see I don't feel well, they go out of their way to try to help me feel better. So I try not to let people worry, because there's no point in living life if you're worried about tomorrow. You gotta live for today. So that's the mentality I live by. And because I live by that, most people see that I have a pretty optimistic outlook, and therefore they treat me the same.
Yeah. See why I love being a rheumatologist? So are there have you got any questions for me for a start?
No, actually, I don't think I do, no.
Any questions from the audience for Claudia? Maybe I've asked them all.
I think that was very, very nice. Thank you so much. But of course, if we have questions, we didn't touch on.
If you think of some while Mark's doing his basic science bit, then we can ask at the end.
Okay.